Thank you, Matthias, for the kind introduction. I'm afraid I'll have some more numbers to go through from some of the research that we've done with GE Healthcare, so I'll be going through those in the next few minutes. As mentioned earlier, I'm a consultant radiologist. I switched over from looking at brains to looking at bones. I'm an MSK radiologist now, and I'm also the AI lead for Oxford and our Thames Valley Imaging Network. Just some of the collaborations that I have. So today I'll just be going through sort of the existing role of imaging in the emergency department and paint the picture of how we are dealing with things at the moment, what the challenges are in terms of image interpretation, and a lot of those were touched upon in the morning because we had some wonderful speakers talking about the workload pressures that we have, and then what is AI doing? What tools are out there at the moment that can help with some of those challenges, and also why they aren't being adopted at the moment. So just as a bit of background, these are some numbers from the UK. So if you turn up to A&E, in about 2/3 of cases, you'll have some sort of a scan. If you're unfortunate enough to be admitted, you will have 5 scans during your stay. But imaging has been shown to reduce unnecessary hospital admissions. It's been shown to reduce unnecessary procedures. And as a result, we've got a constant increase of use of medical imaging throughout the world. Unfortunately, certainly in the UK, but I'm sure that's the case elsewhere as well, the number of radiologists hasn't quite kept up with the imaging demand. We're spending a lot of time, a lot of money on outsourcing of cases from our hospitals. And despite that, we can't quite catch up with the numbers that we have. We also have some reporting radiographers who are predominantly looking at plain X-rays, but the practice varies across the country. On average, about 30% of our plain X-rays are reported by reporting radiographers, but that still hasn't quite gotten us to the point where we're on top of things. In the emergency department, this is sort of our typical imaging pathway. So if you come in, you have your scan done. If you have a CT or an MRI scan, it normally gets reported by a radiologist. If you have an X-ray, most of the time there isn't a hot report available. It gets looked at by ED physicians or nurses in ED, and generally the turnaround time is 2 to 3 days, by which time you've already taken your clinical action. So it's more of a governance tick, and just in case you miss something, rather than providing an active, making an active part of the patient management at the point of care. As a result, sort of image interpretation is a core part of what A&E doctors do, and the Royal College of Emergency Medicine put that as part of that core part of the clinical curriculum. But as we know, A&E doctors and other staff in A&E have a broad range of experience and expertise. They don't have any dedicated imaging and image interpretation. They work in a busy environment with beeps everywhere. They're not in a dark room looking at X-rays. They might be looking at it on a just a normal computer. And as a result, they make mistakes, understandably. So these are some published numbers. Around 5% of fractures get missed on initial presentation to the emergency department. And the vast majority of diagnostic errors that occur in the A&E are because of misinterpretation of X-rays. Going forward, there are some other things that can happen. So you might not be looking for these things because you haven't got training, you aren't looking for it. But there have been cases where junior doctors have been looking at images and they've been left to their own devices. And as a result, cancers was missed. And this was we have a regulator called the Care Quality Commission who looked into this and found that junior doctors without appropriate training were left to look at X-rays, and that led to patient harm. So the question is, can AI help with this? Can it help drive efficiency and faster turnaround times in ED, and can it support our ED colleagues who are there at the moment trying to deal with this? We've had a little bit of an explanation earlier about what AI is, but essentially it's an overarching term, and it's something that we've been using in radiology for over 50 years. And you used to call it computer-aided detection, and the adoption at that time was pretty low. The turning point most recently came in the mid-2010s when deep learning was applied to computer vision techniques and showed that there was a big jump in performance. And then that led to applications like self-driving cars, like facial recognition, and in the healthcare medical imaging, so predominantly radiology, but also dermatology, ophthalmology, and pathology have also seen growth of AI tools. And there's been a lot of research in this area as well. So the term computer-aided diagnosis has fell out of favor, and machine learning and deep learning has become more in vogue. So this is a PubMed search of how many papers have been published. A little bit out of date now, but you can see there's a exponential increase in the amount of research that's happened in this area. And as a result, we've had a year-on-year increase in the amount of tools that have become available. So this is a graph showing FDA approvals, and you see the yellow bars is radiology, and it dominates of how many FDA approvals have been achieved by AI so far. And with X-ray being the most common modality, a lot of focus has been on X-ray based tools. There are 28 CE cleared chest X-ray interpretation tools and 19 MSK X-ray interpretation tools available on the market. And again, as mentioned this morning, X-rays form the bulk of the work we do, far outstrips any other imaging modalities that we do. But yeah, the adoption of AI is still pretty slow. And why is that the case? And there are quite a few hurdles on the road to AI adoption. It starts off with having the right problem to use, to solve. Unfortunately, a lot of the AI tools that have been developed have been technology-led. So advances in computer vision technology, the fact that we had large databases of imaging, we went for interpretive technologies. And perhaps now we're learning, now that we've got the technology, how do you best put it into patient pathways and clinical pathways? And that's slowly now leading to further adoption. You have to have the right type of data to be able to train the algorithms. You want to make sure that the evaluation, the clinical evaluation that was talked about a little earlier, has been done properly. And again, that's an area which takes time. And if you as GE, you guys know how long it takes to take a new diagnostic technology or medical device from idea to the market. So I think we're expecting a little bit too much from AI to be adopted so quickly. The technology's been around properly for less than 5 or 6 years, and actually the degree of adoption has been pretty good. Compare that with tomosynthesis, for example. It's a technology that's been around for similar, if not longer, but the adoption takes a while, and I think we should be realistic about how quickly we're going to see adoption. But it's a process, and it's a process that we're going through at the moment. And at Oxford, we have an entity called NCME, which is the National Consortium for Intelligent Medical Imaging, and it's a collaboration between healthcare, academia, industry, and patients. We've brought together lots of hospitals, lots of industry partners, along with the healthcare and patients, to sort of go down this journey together and answer these questions, so we can go towards adoption. GE Healthcare is one of the partners that we worked with, and what we want to do is, like I said, answer some of these barriers around clinical validation, around optimal workflow integration, but also what benefit do you get if you invest on it, and if you spend money on AI, because healthcare has a limited budget. And if you're not spending, if you're spending money on AI, you're taking it away from a nurse or a doctor that you could employ. So what is the benefit? And there are multiple steps that we go through. So a lot of the work initially is done around algorithm development and training, finding the right type of data sets, doing evaluation on independent but retrospective data sets. Reader studies, which is something I'll talk about quite a lot today, is a way of looking at the impact of the AI on the clinical end users, be it radiologists or radiographers. Then the step which we're moving towards now is prospective validation. So if you drop this tool into the live clinical environment, what benefit does it bring? And through that, generate data around the clinical impact, but also the health economic impact. And then we've done this work across the whole life cycle of AI products, right the way from the initial concept, where we worked with sort of university academics and industry academics, all the way to live deployments. So that's some of the work that we're doing. And with GE Healthcare, our work is mainly focused on reader studies. So reader studies is a type of a diagnostic accuracy study, and is based on testing of AI, of the clinical end user with and without AI. So with the current method and with the new enhanced technique. And it's a quite commonly and long-standing technique for user to evaluate diagnostic devices. And what it does is allows you not only to evaluate the accuracy of the technology, but also what the impact is of that technology on the clinical end user. Because most of these tools are diagnostic aids; they're not standalone medical devices or standalone diagnostic devices. What they're doing is providing an extra output for the radiologist to have a look at and make their decision. So, what impact is it having on their performance? They also allow you to sort of control what goes into your data set, and you can get a variety of different types of readers to see what the impact is on people of different seniority, of different specialties, and they're relatively quick to perform, so you can generate evidence fairly quickly. And it's been a key part of the research we've done so far, and there's been quite a lot of literature around them looking at how different AI tools are helping radiologists. So the way it normally works is that you generate a data set and work out what you want to be in there, what pathology mix you have. You then establish ground truth, which generally is done through consensus of experts, but you could have things like follow-up imaging or pathology results, for example. Then you let the readers look at the images without the AI. Then you sort of give them a gap so they forget everything, and then do it with AI. And then you have a look at what the results were, what the impact was. And the way we've developed a web-based platform to do this as well, so you can get readers from different sites looking at the images, and it's got a sort of web-based ICOM viewer with a reporting simulator, so you can it's a online clinical simulation platform. And we've done this to evaluate the critical care suite. So the critical care suite, for those who don't know, is an on-device AI solution, and it provides information on the image quality of the X-ray, and then two clinical applications, which is the presence of a pneumothorax and the position of the endotracheal tube. So the first reader study we did was on the pneumothorax algorithm, and this is able to detect the presence of a pneumothorax, provide an overlay of where it is, provide a probability score about how likely it is for the abnormality to be present, and your sort of binary outcome can be adjusted, but the standard score is 90%, which is what we use for our study. In the emergency department, pneumothorax detection can be challenging. It's mostly done via plain X-rays, but you've got unwell patients. You haven't got sort of beautiful outpatient PA radiographs. You've got patients who are slumped or supine. So the quality of the images is variable. Quite often, you'll have people who are reasonably well or have distracting injuries, which mean that they're not focused on their breathing so much. And like I said, it'll quite often be the junior doctor or a middle grade doctor in the emergency department who'll be looking at them. So even in the normal scenario, trying to detect pneumothorax, it can be challenging. I'm sure you guys have seen that there is a pleural marking at in the left lung, but this is sort of the typical image that we get in the emergency department, and that becomes a lot more challenging. So what we did with the MRMC study was to look at the measurements of the AI against this gold standard, but also looking at what the impact was on non-specialists. So we got 18 readers from 6 different clinical specialties, and then for each one we got a consultant, a middle seniority, and a junior person, and these were recruited from multiple hospitals across the Thames Valley region. Following the protocol I described earlier, we had 400 chest X-rays that they looked at, buffered with a 4-week washout period, and this was done using the cloud-based platform that I described earlier. And through that, we were able to get sort of readers all the way from the south coast all the way to Glasgow. So again, sort of having that centralized platform really helped to be able to get participation from a wide variety of places. And this was a standalone performance of the AI. So the area under the ROC curve is sort of a composite overall evaluation metric of how well the tool performed. And the score goes from 0 to 100. So, the critical care suite performed at 94, which is pretty impressive. And then we've also got the sensitivity and specificity numbers. Like I said, these are, depending on where you set the threshold, can impact what the sensitivity and specificity looks like. So with the default value that we use of 0.91, we had quite a good specificity, but sensitivity was also reasonable. Like I said, this could be adjusted in the clinical scenario depending on where you are. But the interesting part was this, with the impact on sensitivity and specificity of the readers. So without AI, people didn't do so well, or they improved with AI, basically. I think the graphs are a bit messed up at the bottom, but essentially the left-hand side is the sensitivity, the right side is the specificity, and this is looking at the change in performance with and without AI. But the most interesting part was this, looking at the different readers. So you can look on the blue bar is without AI, and you can see there's a marked difference between the readers, especially the junior and the senior ones. But when you provide them with AI, which is the orange bar, you sort of equalize their performance. So you're pulling up people to an expert level by providing them with this invisible helper, as Matthias described earlier. And this was the performance, the improvement in performance. So the orange dots are the junior doctors, and the middle grade ones, and the blue dots are the more senior doctors. And if you look at it, again, you've got a lot of variation, and what AI does is to help reduce that variation by providing a helping hand. What we also found interestingly was that as people saw more and more results from AI, they became better. So we split our evaluation into 4 different modules, and the performance in the last module was better than the first one, even though we're not teaching them, but because they're getting an answer straight away, we are teaching the workforce and training the workforce through AI. It also improved their confidence in the diagnosis, so potentially reducing their reliance on having to call up the radiologist and say, hey, I'm not so sure about this, or going to a senior doctor within their own department. So yeah, in summary, there was an overall improvement in sensitivity, and particularly for the junior readers. But the main thing is, you're bringing up people who are not doing so well and getting them up to expert standard, which is quite powerful. We did a similar study with the endotracheal tube application. So again, it was performed in a similar way. We had 400 chest X-rays again, and split into 2 phases. And we found similar results. So I think the task here was slightly easier, finding out exactly where the ET tube is easier than finding difficult pneumothoraces. But we still found an improvement across all groups. The quantum of improvement wasn't as much, but still, we found an improvement across all the different categories, and there was an equalization again between the different groups. And in fact, the junior group performed better than the senior group with AI, which is interesting. And again, there lies in the education piece, and I'll come to another study that we did a bit later, where we need to develop trust within AI, because clinicians are ignoring AI even when it's correct. And how do we go ahead and do that in the future? So apart from G, another sort of extra application we've looked at is a wider chest X-ray tool, which detects 10 different abnormalities on X-rays. Similar protocol, we had 500 X-rays this time. We got data from multiple centers, so Edinburgh as well as Oxford. We had 30 readers reading 500 X-rays twice, so we had 30,000 data points in total, multiplied by 10 different abnormalities, so lots of data. And we had people, who'd be looking at these chest X-rays in the front line with a range of seniorities. And again, the AI performed pretty well. So again, if you look at the sensitivity and specificity numbers, they're all pretty reasonable. But this was the overall numbers. The red dot at the bottom was the reader performance, the pool reader performance without AI. And then with the AI, it got closer to to what the AI is doing, but not quite as well as AI. So people are underperforming AI even when AI is available to them, and they don't quite trust the results. Um, and this is the same data but displayed slightly differently. So this is broken down by all the different abnormalities that we looked at. So here the green dot is the standalone AI performance. The blue dot is the reader performance without AI, and the red dot is the reader performance with AI. So everybody improved for all the 10 findings with AI, but nobody performed as well as AI, which was quite interesting. And the improvement was significant in 8 out of the 10 abnormalities, apart from the bottom 2. We also split the data up into patient-facing and radiology specialties, because we had reporting radiographers there as well. And again, the results were similar. So the patient-facing specialty, the junior doctors improved by a lot more, but the radiologists improved as well. And again, they didn't do as well as the standalone AI tool. The final study I'll briefly talk about is a fracture detection study. Again, a common thing that you would see in ED in terms of X-rays. So we've done a similar reader study looking at fracture detection using a tool called Gleamer, which has been, I think the company is based in Paris. Similar setup, 18 readers, 6 different hospitals, different grades. A bit more challenging because you've got lots of different body parts, so how do you decide what you put in your data set? So we went to NHS Resolution, which sort of looks at the litigation cases in the NHS, and looked at what proportion of cases were litigated upon in the last few years, which body part. So we based our data set as a proportion based on what was being missed, and then the hospitals were getting sued for. And again, similar results. All the different specialties improved with AI. The improvement in the juniors was the biggest, and the seniors are the least trusting of AI. So there's a pattern emerging here. And it's like I said, it's a consistent thing we're seeing. So on the left is sensitivity, on the right is specificity. One of the other challenges of AI is the false positives. And the idea being that actually, if we have too many false positives, we're going to have lots more images happening. But actually, when you test it with the clinical end user, the specificity doesn't worsen, which is reassuring. And for the last study that I talked about, LUNAT study, one of the questions we asked was, if you had, how do you feel? Like, are you likely to order a follow-on CT now that you've looked at this AI result? And with AI, people were in theory asking for fewer CTs and fewer radiologist opinions. So again, there's a value that AI is adding there. So yeah, I'll summarize there. It's there is a need for increased efficiency in the emergency department. Our colleagues in the ED are getting slammed from all sides, and they're heavily reliant on imaging to make their clinical decisions and move patients along. AI offers potential to enhance and extend that interpretation, and provide that second help to our colleagues. And there are multiple potential use cases. I've touched upon the X-ray ones, but also there are use cases within CT, within point-of-care ultrasound, which are again sort of imaging modalities that are commonly used, but also in terms of patient triage and prognostication as well. We've done some of the studies I've talked about today, but we do need some more evidence around sort of that real world efficacy of these tools when you drop them in outside the lab conditions, and we're working on some of those in Oxford at the moment. Thank you.